My name is Elsie Scott. I'm President and CEO of the Congressional Black Caucus Foundation. And I first want to thank Tanya Speed for hosting us here this evening, and thank all of you for coming out. And especially, we want to thank Congresswoman Donna Christensen for joining us this evening. We have been doing a series of what we call intimate conversations with members of the Congressional Black Caucus as a build-up to the 40th anniversary of the Congressional Black Caucus. There were 13 original members of the Congressional Black Caucus, and we have taken 13 issues, and we're interviewing 13 of the present Congressional Black Caucus members to talk about these issues. But what we're doing with these intimate conversations, we are preserving history, because what we're doing is we're showing the tie-in between the original 13 and some of the ideas that they had as to why we needed a Congressional Black Caucus, what was the importance to the African American community, and how those issues are still relevant today. And so we are very pleased that we have this online virtual library, which we launched in 2006 with the assistance of Dell Incorporated, who's our founding sponsor, the University of Texas, which is our digital sponsor, and Howard University, which is the official repository for the Congressional Black Caucus. And so because of the support of our founding sponsor, as well as our university collaborators, we have been able to put up 6 exhibits. And we are working on an exhibit on education. I still don't know how we're going to do an exhibit on education, because so many of the Congressional Black Caucus members have been very engaged in issues around education. And so we're going to have to narrow it, otherwise the server may collapse. But this, this project is a dynamic project. It continues to grow because there are documents that are continuing to be produced by the Congressional Black Caucus, and there are documents that we are still discovering as we work with the Congressional Black Caucus members to help them to understand the need to preserve their documents. When we went through Katrina, it became clear to all of us the need to digitize documents, to have online storage, because so many papers, so much good history was lost in New Orleans and other parts of the Gulf because of the lack of storage, a lack of digital storage. And so that's part of what we're doing. In addition, we are introducing the work of the Congressional Black Caucus members to the world, because our virtual library is being viewed by persons around the world. And it's for the first time many of these people are becoming familiar with the work of the Congressional Black Caucus.
Today's topic is going to be health care, and we're pleased to have Representative Donna Christensen of the Virgin Islands here today to discuss her experiences as a member of Congress, as a member of the CBC, and as advocate for health care reform and equity. On the Avoice website at avoiceonline.org, you can find many documents, letters, and artifacts of the history of the Congressional Black Caucus. One of the goals of the CBC has to ensure that minority and other underrepresented groups have access to comprehensive health care and services. They have worked tirelessly to expand existing programs such as Medicaid to cover underserved communities and bring women's health to the forefront. Specifically, Representative Christensen has fought to provide incentives such as tax credits to primary health care providers and establish practices in underserved areas, and sought to encourage managed care organizations to contract with these providers. Now, all of this information is online and free. And all of these years later, we can review these documents and imagine in 40 years, people will be able to review this video and see what inciting things we have learned today. Now a little bit about tonight's event. Think of this as an Oprah-like show. And you all are privileged to get a front row seat to hear history from the history maker. This event will be videotaped, preserved, and edited for streaming on the Avoice site. Now I'd like to thank our host for the evening, Ms. Tanya Speed of Washington Premier Consulting. Tanya was actually at our first event, which was a cultivation event, and really help us formulate this series. So we're really grateful for that. And her husband, he was very helpful as well. She has also graciously agreed to conduct this interview with the Congresswoman. And just a little bit of information about Ms. Speed. She was recently elected to the Congressional Black Caucus Foundation's Corporate Advisory Committee and has at least 20 years of experience in federal government affairs. Her firm represents a range of public and private clients in healthcare reform, Medicare, financial services, and small and emerging businesses.
I went home in 1975 and began practicing first in the emergency room and later in 75. And later on went into private practice, but got involved in some issues at home. Things that are really very unique to the Virgin Islands, and organized coalitions and so forth. And that was a lot of work for a mother trying to raise, at least I think I had one child at the time. So I joined the Democratic Party in around 79, 80, and became a member of the governing territorial body for the Democratic Party at home. Assumed some offices in there, then went to my first convention, and ran for National Committeewoman. So for 12 years before coming here, I was Democratic National Committeewoman and attended all of the conventions and was active in local politics, not so much in elected office except for National Committeewoman and maybe one term on the school board. But so I was doing both. I was practicing medicine and being involved in local and national politics. And so when the seat became open, I was urged to run. I had never really planned on it. I planned to just continue practicing, but the seat opened up and it was an opportunity to serve my community in a different way. And as a family physician, you get to see a lot of things besides the specific complaint that the person is coming in with, whether it be a headache, a stomachache, or whatever it is. You get to talk, you get to know the person, you get to know the family, you get to know the environment in which they live. And there are a lot of things that a doctor in an office practice can't change. So this gives me an opportunity to begin to try to change some of the environmental factors that make people sick. Well, I had to convince some men around home that I could serve in this position. That was probably my first big barrier. It had been previously served by two men. So that was a big barrier. And I don't think I could have done it if perhaps my children weren't grown. My youngest daughter had just gone to college. I do have colleagues who came with young children, but that's a particularly hard thing to do with the demands of the office. So I came just probably at the right time in my life, but I did have to convince some women also that a woman could do this job. And they were sort of tentative at first. Actually, I lost my first primary and ran a second time. I lost my primary in 94 and then ran in 96 against two men, but prevailed in a runoff. I had to. It was a long struggle to get here, but I guess I was able to convince some people that perhaps I was tough enough for the job. And after coming here, it hasn't really been much of an issue. I came in with a ready-made family in the Congressional Black Caucus, and then we had a very active caucus on women's issues when I first came in. And so there was a lot of support there. And I haven't really felt that being a woman in Congress has affected me in any way. Perhaps more so at home. I think some of the people who are in office at home still adjusting. I think they treat a woman differently than they would treat a man in my office. But up here, it hasn't been a problem at all. Let me just first say that if it wasn't for the Congressional Black Caucus, I probably wouldn't be on Energy and Commerce. And I'd be an outsider looking in, trying to have my voice heard, but never really in the workings of getting this historic piece of legislation crafted and passed. But as I'm the only physician even on the Democratic side of Energy and Commerce. So
I didn't know that.
yeah, and there's a nurse and a physician on the Democratic side. So it was a very, I think I played an important role, especially in terms of representing the issues of minorities, people of color, people in rural areas, and women.
Yes.
Leading the Congressional Black Caucus, we developed a set of principles very early on, before we even started to work on legislation. And we drafted those principles in conjunction with the foundation, with community organizations, with professional organizations like the Black Nurses and National Medical Association, National Dental, and so forth. So we went into this prepared, saying that one, insurance is not enough, because it really only accounts for 20% of the disparities that we see in healthcare, and two, that health disparity elimination or health equity had to be a part of this. And so we had legislation that we've been introducing with the other minority caucuses as a tri-caucus over the last 8 years, and we used that as our blueprint. And what we sought to do was to include the provisions that were in our bill into healthcare reform. The three caucuses, the Hispanic, Asian, and Black caucus, once we developed principles, we stuck to them. We had meetings at the White House. But there were some particular areas like community health centers, which was championed very much by our whip, Jim Clyburn, but making sure that those provisions stayed in the House bill. The community health worker grants that can go to communities was one amendment that I had. I was originally interested in adolescent medicine, so we put some specific language, because a lot of times they talk about pediatrics, but adolescents are a specific group that have specific needs, so we included that. Some of the big issues for me were the comparative effectiveness research part of the bill, trying to ensure that when the research is done, we're not left out as we usually are, making sure that subpopulations, that women, that people with disabilities would be included, because if we are not in the mix, nobody knows what is effective treatment for us. And several other areas were very important to me. We wanted to also work with the Congressional Budget Office and we did work with them, we just were not successful in having them score prevention. The bill as it stands is over $900 billion, but we feel that there are significant savings in there, and we had to compromise on a number of issues, including issues involving the territories that we didn't feel we really needed to, because this bill will have savings as it's being implemented that will bring down the cost of the bill over the 10 years. First of all, we were able to get disparity elimination language throughout the bill, so that almost every task force or commission has within its charge the elimination of health disparities. We were able to also require that data be collected by race, ethnicity, and other socioeconomic factors, something that is, is not uniformly done right now across even Health and Human Services and the federal health agencies.
So true.
So, but I think the biggest thing that we were able to accomplish, and I think the most far-reaching thing that we were able to accomplish, was with the Office of Minority Health and what was the National Center for Health Disparities and Minority Research at NIH. For the Office of Minority Health, we were able to create new offices of minority health in agencies that did not have them. So Food and Drug Administration, for example, the Food and Drug Administration had never had an Office of Minority Health. And CMS, the Center for Medicare and Medicaid Services, had not had an Office of Minority Health. So we now have new offices of minority health being set up in those agencies. And for something like Food and Drug Administration, where all the drugs have to be approved and they don't have a minority component, we're expanding them at the CDC and in Substance Abuse and Mental Health Administration, another very important area. So we've really strengthened the Office of Minority Health in the Department of Health and Human Services. And then in addition to that, something that we'd worked on for several years with a lot of people, even outside of the Congress, is elevating the center at NIH to an institute. And the institute is now an institute, which means that there will be more funding, that it will have more authority over all of the research trans authority over all of the research that happens at NIH, and looking at how it affects different population groups. The funding that they have really does a lot to support the development of the research infrastructure at minority-serving institutions so that they'll be better able to compete and do research. So that one accomplishment can have very far-reaching impact. I've been in for 14 years. I started going to Haiti with Congressman Conyers, and I've seen us do a lot of stops and starts. But this time Haiti really needs us to be there until they have reconstructed Haiti in the way that the Haitian government and the Haitian people want. And that's the other thing. We want to make sure that this is how Haiti wants it done, not how everybody else around the world thinks they should do it, and be there in a supportive way. In terms of healthcare, I had a chance to visit Haiti, and I think I was visiting it at a time when the healthcare needs were transitioning from the acute trauma. The hospital, the tent hospital that we visited, was now doing C-sections. They had no OBGYN, so the general surgeons that were there had done 3 C-sections. They were taking care of people with respiratory disease, heart disease, and so forth. So it's now transitioning, and we need to be addressing some of the more chronic health needs that have not been adequately addressed. We need to help, and these are the areas that we're looking at where we can be helpful and what we can do to be helpful, to begin to train healthcare professionals to be able to continue the work that the medical schools there were doing and maybe enhance on it somewhat. We're looking at even the National Institute for Health Disparity and Minority Research is funding some of their grantees to continue to expand their work and do work in Haiti. We're looking at training community health workers. I happened to go to my alma mater, GW, to a Haiti day that they had. And in discussing, in one of the discussion groups with one of the Haitian doctors who had been working in Haiti, in addition to wanting to go back and being asked about fulfilling the need for training, one of the areas of training that they thought was very important, and I think it's very important there too, is the community health worker. And that community health worker is probably someone who is going to be able to, who's going to stay in Haiti and continue to work among the community, and they'll be of the community. And so we're looking at how we can support some of those health areas, and looking forward to having a conversation with some physicians, Haitian physicians here. The ambassador to the UN, who has referred to me as the person I should talk to, Paul Farmer, who is President Clinton's deputy, and John Ruffin up at the Institute, to see how we can really do what is needed, not what we think is needed.
Sure.
And one of the areas that we have not touched on that I know you're passionate about is HIV and AIDS. You and I went to South Africa in '07. So if you could just touch on some of the work that you have done both domestically and internationally around the whole problem of HIV and AIDS in the global Black community. Okay, and let me just start out by saying in healthcare reform, we did do 1 or 2 things that relate directly to AIDS. One is that in Medicare, ADAP payments for prescriptions can count towards the true out-of-pocket costs. And Medicaid, the states have the option and the ability to use Medicaid to pay for early HIV treatment, which was a bill that's been around for a long time that's never been able to be passed. But in terms of HIV, we're still working on that national plan, but we've had the Minority AIDS Initiative that actually started when I came in, when Congressman Stokes was still there and Maxine Waters was the chair of the caucus. And I got an opportunity to really learn at their knee, you know, how to negotiate these issues, because trying to get the Minority AIDS Initiative started was not an easy task. There were many in the department that did not want to have money go directly to community organizations, that did not want to target the dollars to communities of color.
And but we had some inside players as well who were on our side, who worked from the inside. And we were able, well, Maxine and Congressman Stokes played good cop, bad cop, and got it done under the Clinton administration. They really did. And then, so once he was gone, then it was really left to me as chair of the caucus to increase the funding. We started out with $158 million in '98 and got it up to about $400 million. And we're still trying to increase it. We went to the budget this year saying that it needed to be more, around $800 million. So we've been continuing that and trying to get it back to where the original intent was, which was building capacity in our communities. We've been working with the clergy on their HIV and AIDS Elimination Act. They were up on the Hill for a while. One of our current issues is ADAP funding. That is the AIDS Drug Assistance Program. And it has never, over the last few years, it's never been budgeted to a point that everyone who needs a treatment, who needs to be on ADAP, can get it. So there have been waiting lists. And in some states, people have died on waiting lists. And the waiting lists continue to grow, and people are dropped, services are curtailed. And so right now, what we're trying to do is get into the supplemental bill, more ADAP treatment. I've worked with Congresswoman Lee and Congressman Payne on PEPFAR. And when Dr. Scott and Congresswoman Lee and I went to South Africa, it was really to look at some of what PEPFAR was really doing, the President's Emergency Funding for AIDS relief. And we were able to see some of that money really working in South Africa and out in the real boonies of South Africa, I would say. I mean, down in the country, but it was really working. And so what we were able to do in the last Congress was expand that, because as a Caribbean person, I'm always fighting for my region. And only Haiti and Guyana were included in PEPFAR initially, but we were able to expand it to all of the Caribbean countries now. And so that was some of the work that we did. And working, well, I would have to give Congressman Payne and Congresswoman Lee the credit for this, but increasing the funding for PEPFAR. When President Bush was leaving, he said that he would double from 15 to 30 billion over 5 years, and they got it up to almost 50. They got that funding for PEPFAR up to $50 billion, but what happened was there was a critical need in the Native American Indian community here, so $2 billion went to them. So it was 48. So there was I think it was still a tremendous success.
My question goes back to, excuse me, one of the comments that you made about agencies being created at CMS and FDA. What are some of the short-term goals that you would like to see with those agencies and what they plan on doing?
Okay. Well, the two particular issues, let me talk about FDA first, because you might remember, and this is something that I got to work on as I came to Energy and Commerce, was the bill that the Family Tobacco Smoking and Tobacco Prevention Act that gave FDA the ability to regulate tobacco. And there was a serious question about, should we, as African Americans, support that bill because it did not ban menthol. So we are looking to that office at FDA to make sure that they follow through on the research and the trying to determine what the link is between menthol, cigarettes, and cancer, because African Americans smoke more menthol. Well, 80% of African Americans who smoke menthol. And whether that is the reason or not, we get lung cancer more quickly, younger, and die more from it if we smoke. So if there's a link, we need to know that. So that's one area. But also in the drugs that come out, we want to make sure that when medicines are approved, that they're tested in every subpopulation. So because there are medicines that work better in African Americans or don't work as well in African Americans. And we need to know that. And we look to that office to really monitor that. In CMS, we had a recent experience with one of the end-stage renal disease drugs when they were changing the guidelines. Now, it turns out that African Americans, who make up a large percentage of end-stage renal disease patients on dialysis, need more of this medicine to keep their blood levels, their hemoglobin levels, within a certain range. And the guidelines set the level a little lower, and were restricting the use of the medicine. And we wanted to make sure that African Americans could get the medication if they needed it. And we asked them, well, the CBC wrote to them and told them this is our concern, and we wanted some flexibility, and that we wanted to know, after they set these guidelines, how it impacted the African American community. Well, a year and a half later, in speaking to one of the people at CMS and asking the question, well, what happened when the guidelines changed to African Americans? They told us that they did not collect data by race and ethnicity on that. So we expect that that office there would monitor some of these issues, and there are disparities in the Medicare and the Medicaid population, and we expect that office to really be a help in monitoring and closing those gaps for us.
My question for you is, with the new healthcare reform that was just passed, what are some of the immediate privileges that we can look forward to? Thank you.
How old are you?
I'm 24.
Well, you can stay on your parents' insurance for 2 more years. That's one. So that's an immediate one. Insurance companies will not be able to drop you if you get a catastrophic illness, as some have done. We've already seen some of the impact on the increases in premiums because of the transparency that's required. What are some of the others? If for someone on Medicare who is in the Medicare prescription drug program, if they get into the donut hole, there's a $250 rebate before we really start to close it. Those are some of the areas that come to mind. Oh, there's the early retiree insurance program. There's also the high-risk insurance plan for those people who have pre-existing disease until we get to 2014, when we can prohibit exclusion for pre-existing diseases. So those should be coming online very shortly. But in the education area, remember that we did a health and education reconciliation bill, so there's more funding for Pell Grants. There is additional funding for HBCUs and minority serving institutions for community colleges. And also, one of the areas that starts very early, and I didn't talk about this, but this is an important part of healthcare reform, is the issue of having to train the healthcare workforce that we're going to need very soon. And in that, since we have to expand the healthcare workforce and the minority representation in that healthcare workforce is so low, there are provisions that specifically speak to increasing the diversity of the healthcare workforce. So there are specific provisions on minority serving health profession schools, and developing and providing programs for underrepresented minorities in the healthcare workforce. And that could be physicians, nurses, pharmacists, physician's assistants, nurse practitioners, nurse faculty. So we've done a lot to ensure that as we move forward, that the healthcare workforce looks more like the country.
Excellent. And there's also one other little provision called the Class Act that allows for long-term care coverage, and that will take place in another 5 years or so. But that was tremendous inclusion that I know that you supported among a number of others, because it helps, particularly if you come down with any type of disability and will need assistance, then there's a benefit for that now.
Yes.
Exceptional. Anyone else? I said one more, but if there are no more, thank you again, Congresswoman Christensen.
Well, thank you. Thank you. Thank you.
Wonderful.
And thank you to the foundation and to Avoice for inviting me to participate in this program.